Thank you, Chairman Pitts, Ranking Member Pallone, and members of the subcommittee to talk to you about Medicare Advantage. As a senior fellow at Mathematica for the past 20-plus years, I've been examining Medicare Advantage for a long time, analyzing trends in plan participation, enrollment, and benefits, looking at market dynamics, and studying the implications for beneficiaries, working with the Kaiser Family Foundation and others. My testimony today makes 3 points that I hope will inform the congressional debate on the Medicare Advantage program today. My independent findings, I should say, in general, are closely aligned with the positions and opinions expressed by MedPAC. First and foremost, and we've heard this in a few other places here today, the MA program is strong with rising enrollment and widespread plan availability that's expected to continue through 2014, despite the concerns that the cutbacks in payment would discourage plan participation or make plans less attractive. There's 15 million people in the program, 29% of all beneficiaries, an all-time high, although it varies a lot across the country, and I think it's important to recognize that healthcare is local and the circumstances are different. The kind of care Dr. Margolis mentions happens in some places and not others. Second, despite concerns over plan terminations in 2014, there are almost as many new plans entering in 2014 as terminating, and since the ACA was enacted, average and premiums to enrollees have declined, and they'll still be lower in 2014 than they were in 2010. Exit and entry are essential characteristics of a competitive market. Medicare beneficiaries today have an average of 18 Medicare Advantage choices, as well as the option to stay in the traditional Medicare program and with or without a supplement. Medicare beneficiaries can keep their plan. It's called Medicare, whether you're in Medicare Advantage or Medicare Traditional. Second, it's difficult to see the rationale on a national basis for paying private plans more than Medicare currently spends on the traditional program, particularly when there's so much concern with the deficit and debt. Medicare has historically aimed to set payments to MA plans below or equal to what Medicare would expect to pay in the traditional program for beneficiaries who enroll in the plans. This changed in 2003, and by 2009, payments were considerably higher than Medicare would have paid for the same beneficiaries if they were in the traditional program. This costs every beneficiary more in added Part B premiums, and it provides little incentives for MA plans to become more efficient. When I examined the 2009 plan bid data, I found wide variation in MA plans' costs relative to traditional Medicare spending, even controlling for plan levels, plan types, and payment levels. That suggests there was room for a lot more efficiency in the program, variable across plans. And the policy changes that were in the ACA reflect recommendations that Congress's own Medicare Payment Advisory Commission has advocated for years. Third, many of the concerns raised about 2014 offerings, either to my mind, from what I've looked at, are not consistent with the evidence or inherent part of the way competitive markets work, and they're already addressed by protections in place in the program. Only 5% of beneficiaries, of enrollees in 2013 will have to shift plans. Most will be able to stay in the same type of plan. The average premium was down 21% from between 2010 and 2013 for a beneficiary, and premiums are stable in 2014. Some beneficiaries will see their premiums rise in 2014, but they'll still be paying less than 2010. And if historical patterns hold, some of the beneficiaries will switch around so that they can get a better deal. Clearly, payment reductions can discourage plans from participating in Medicare Advantage, but this doesn't yet appear to be an issue. And Medicare has a number of protections for this, such as network adequacy and quality standards, required notice of change in plans and provider networks, and other means. Because MA choice is voluntary, there also is the option to return to traditional Medicare. In its 2013 March report to Congress, MedPAC concluded that the payment changes under the Affordable Care Act have improved the efficiency of the program and may have encouraged plans to respond by enhancing quality, all the while continuing to increase MA enrollment through plans and benefit packages that beneficiaries find attractive. I believe my analysis and testimony is consistent with MedPAC's conclusion. Thank you for your time, and I look forward to any questions.